Pacific, members of the team, am I audible?
Yes, we are audible.
Okay. So I think it's time and we can start the webinar. We can start with the proceedings now. Okay, so a very good afternoon, good evening, or good morning to everyone, depending upon which part of the world you are joining us today. My name is Bhavneet Bhalla, and I am joining you today from India, and I serve as a member of the TORG Global Education and Training Committee. So, on behalf of the Operating Room Global and the TORG Global Education and Training Committee, I am delighted to welcome you all to the today's global webinar. So, we are pleased to have a truly multidisciplinary audience with us, which includes surgeons, anesthesiologists, nurses, surgical technologists, perfusionists, educators, researchers, students, as well as healthcare leaders. So, we are currently joined by participants from multiple countries across different time zones. And we sincerely appreciate your time and commitment to continuous learning. So, whether you are joining us from Africa, Europe, Asia, the Middle East, or the Americas, or any other part of the world, you are very welcome to the webinar, and we are grateful to have you with us today. So, all along the webinar, we encourage you strongly to participate actively, and you can keep posting your questions and comments in the chat box. But please do remember to mention your name and your professional title along with your query or the comment. And our moderation team will be actively monitoring the chat and will bring your questions forward during the discussion segment. For those of you who are joining the talk session for the first time, the Operating Room Global is a multidisciplinary professional platform which represents over 260,000 surgical and perioperative professionals from across 110 countries globally, making it the largest global network of operating room professionals worldwide. TORG brings together 42 healthcare disciplines and specialties currently and operates at a not for profit and a non governmental organization, which was originally founded in Nigeria in the August of 2015. And I'm proud to say that today TORG has over 20 active chapters globally, including representation across 31 African countries. So our mission is clear. It is to advance surgical and perioperative care through education, research, advocacy and innovations and capacity building. And with a strong focus on safety, equity and system strengthening also. So TORG is an internationally accredited CPD provider recognized by the CPD group, which underscores the quality and the global relevance of our educational activities. And it is supported by its academic and innovation arm, the Operating Room Global Center for Education, Research and Innovation, which is incorporated in Ireland and which leads all our global agendas in education, research, innovation, as well as our partnerships. We have an affiliated journal, the Operating Room Journal, which is open access, peer reviewed international journal, which was inaugurated in the May of 2025. And it provides a platform for high quality evidence that informs practice and policies worldwide. The TORG is also proud to host its own institutional review board, which is officially registered with the US Office for Human Research Protections, thus reinforcing our commitment to ethical, responsible, and globally credible research. TORG is driven by a volunteer led leadership model by passionate professionals who continue and to contribute their time, expertise, and vision to strengthen the global surgical care. So we are actively engaged with global alliances, including the G4 Alliance, Intersurgeons, and are listed with the Union of International Associations and the Global Civil Society Database, again reflecting our global accountability and research. So without further ado, let's start with the proceedings. I would respect my team members to introduce the first speaker of the day. Over to you.
Thank you very much, sir. I'm Dr. Dagmawi. Good evening, everyone. good afternoon or good morning. I'm a consultant anesthesiologist. I'm also a pain medicine fellow and a TORG research fellow. I'm currently practicing at Manhad Specialty Hospital in Hargeisa, Somaliland. And today's webinar topic, I will be speaking about anesthesia considerations in orthopedic surgery. I hope you can hear me. Can you hear me? Am I audible?
Yes, you are perfectly audible, Dr. Bekele. Please go ahead.
Yeah, you are audible.
Okay, thank you. Is my slide visible?
The slides are visible. Can you please go full screen?
Okay. So the objective of our webinar will be to discuss. Sorry. The objective of this webinar will be to discuss general and specific considerations of anesthesia for orthopedic surgery, and also to discuss the anesthetic implications and management of special conditions in orthopedic surgery. So, as we all know, orthopedic surgery has a high volume globally. And in 2024, the global orthopedic surgical procedure volume was estimated to be around 30 million, according to Life Science Intelligence in 2025. And this volume is anticipated to increase in the coming decades due to multiple reasons, like increased man-made and natural disasters, due to increased access to healthcare, and due to aging population, and so on. So we can classify our considerations into general and specific considerations. So general considerations, I'll be discussing the preoperative, intraoperative, and postoperative considerations. In preoperative considerations, the first one will be age. So when we consider the age, we can consider the two extremes of age, the geriatric and pediatric population. So when we see the geriatric population, most of them often have medical comorbidities. They have limited physiologic reserve, and most of them might be on antiplatelets or anticoagulation therapy. They pose difficult airway management due to change in the fascial structure, that is loss of the buccal fat pad, and edental structures, limited cervical spine movement, and so on, which cause difficulty in the airway management. They are also increasingly having osteoporosis. So these are concerns regarding geriatric population. And regarding the pediatric population, they might have associated congenital anomalies, or some of them might have undiagnosed muscular dystrophies that will predispose them for malignant hyperthermia when they're exposed to certain anesthetic agents like succinylcholine and ibuprofen and so on, other medicinal agents. Comorbidities, regarding comorbidities, trauma patients with physiologic instability, or trauma patients having polytrauma like associated traumatic brain injury, associated chest injury, associated cardiovascular injury, or other intra-abdominal visceral injuries, and so on, will pose great challenge in our management of orthopedic patients. Diabetic patients with poor glycemic control is another concern, and hypertensive patients and their blood pressure control is our concern. Morbidly obese patients, patients with bronchial asthma, patients with COPD, coronary artery disease, and so on. Healthy younger patients are usually assumed to be healthy, but this might be deceptive because they might have an undiagnosed connective tissue disorder, which will pose great challenge during our anesthetic management. Functional status and frailty. We can use different assessment scales for frailty, like clinical frailty scale, mostly used in our clinical practice, and it's directly associated with postoperative outcomes, particularly in hip fracture patients in the elderly. So some of our patients might not be eligible for functional status assessment, so we need to go through thorough cardiovascular and pulmonary assessment in those patients. Regarding preoperative medications, our patients might be on different medications on polypharmacy like steroids, opioids. Regarding their antihypertensive medications, some might have to be escalated, some might have to be discontinued or changed. Regarding beta blocker in the perioperative period, regarding antiplatelet and anticoagulant management, and all this needs to be optimized accordingly in collaboration with multidisciplinary medical team and surgeons. Regarding nutritional status and anemia, we have to make nutritional assessment preoperatively, and we have to optimize anemia because it matters for patients' tolerance of the surgery and anesthesia and for their recovery in the postoperative period. The use of diagnostic tools is another concern. We can use routine lab investigations like CBC, blood group and RH, organ function tests, coagulation profile, bleeding time and clotting time, and other tests according to individual needs. Regarding imaging, also same according to individual needs, we might use cervical X-ray, lateral, or CT, especially in patients which we assume cause difficult airway or those we suspect to have cervical injury or those for C-spine surgeries, especially for cervical myelopathy patients. So those patients with rheumatoid arthritis, osteoarthritis, or anything like that, we might consider this imaging. And also for neuraxial anesthesia, sometimes patients with neurologic manifestations, we might need to screen them with imaging of their spine and vertebrae for administering our anesthesia. This is important both for our anesthetic management and also for medical legal issues. Regarding ECG and echocardiography, depending on patient's condition and comorbid condition, age, we might need to evaluate them with ECG and echo. And some patients might also require pulmonary function assessment with spirometry, depending on patient's comorbid condition and functional status. Our choice of anesthesia technique, it can be general, regional anesthesia, or combined technique. So we choose general anesthesia due to different reasons. One is patient preference and consent. The other is the type of surgery. If it is protracted complex surgery, sometimes general anesthesia might be the preferred technique. And also, if regional anesthesia is contraindicated, we might go for general anesthesia. Our preference for regional anesthesia, it entails a lot of considerations, like regional anesthesia is associated with absent or minimal airway manipulation. Minimal blood loss is associated with regional anesthesia, improved postoperative anesthesia, decreased postoperative incidence of DVT and pulmonary embolism, and decreased post-op respiratory and cardiovascular complications, reduced incidence of postoperative nausea and vomiting, and lower incidence of cognitive changes associated with general anesthesia, particularly in the elderly population, lower incidence of delirium, and early hospital discharge and improved postoperative rehabilitation also warrants the use of regional anesthetic technique. For upper extremity procedures, we can use regional anesthesia alone or in combination with general anesthesia or sedation. For example, brachial plexus block, depending on the site of the surgery, it can be interscalene block, supraclavicular block, supraclavicular block, or axillary block. So disadvantage with this brachial plexus block can be occasional higher, is sometimes associated with higher incidence of postoperative neurological symptoms, but it's transient and self-resolving. And sometimes failure to provide surgical anesthesia might require us to administer sedation or general anesthesia. Others, we might need to give selective peripheral nerve blocks like medial nerve, radial nerve, or ulnar nerve blocks, or infiltration of the digital nerve can be used. Intravenous regional block like Pierce block can be used for short procedures, but it's associated with some complications like it requires continuous tourniquet application or potential for local anesthetic systemic toxicity and inadequate postoperative analgesia since it's associated with shorter duration of anesthesia and analgesia. For lower extremities, most of the time regional anesthesia alone can suffice, but still we can use general anesthesia. So these regional anesthesias can be central neuralgia blocks or peripheral nerve blocks. Spinal anesthesia, epidural, lumbar plexus blocks, 3-in-1 block, sciatic nerve block, femoral nerve block, adductor canal block, or infiltration between popliteal artery and capsule of the knee can be used, and ankle block and so on can be used, or this can be used alone or in combination. Multiple blocks can be used at a time. It can be motor sparing block like adductor canal block and IPAC, for example, for knee arthroplasty for postoperative pain management, or for knee arthroscopy also it can be used. Intraoperative goals for orthopedic surgery is to provide surgical anesthesia with appropriate depth of anesthesia and analgesia, and also to provide optimal surgical exposure by adequate muscle relaxation. The other is proper positioning in order to prevent compression or stretch associated nerve injury. Another major goal intraoperatively is to prevent significant blood loss. That can be achieved by applying different techniques like intraoperative cell salvage technique, induced hypotension, or we can use intraoperative normovolemic hemodilution using crystalloids. We can use pharmacologic agents like antifibrinolytics, like tranexamic acid for clot stabilization, and so on. For our postoperative consideration, post-op pain management is usually our main concern, and that is multimodal analgesia and regional analgesia combination is gold standard for post-op pain management. When we say multimodal analgesia, that means we are using techniques addressing different pain transmission pathways. Can be systemic analgesics administered with the regional analgesia. We can also use systemic analgesics as a breakthrough or rescue analgesic technique. For postoperative monitoring and ventilation, we have to plan ahead, especially for those patients at high risk for ICU admission or high dependence unit monitoring. And also postoperative mechanical ventilation can also be anticipated in certain patients, and we can prepare for that. Sometimes emergencies can happen that we can manage as we go during the procedure. Regarding post-op delirium and cognitive dysfunction, this is particularly a concern in elderly population, and we can decrease this incidence. One is by avoiding general anesthesia, by decreasing the use of anticholinergics, benzodiazepines, and so on. And we can avoid, in our anesthetic technique, we can prevent hypoxia, we can manage pain adequately, and also improve their sleep pattern. Sleep disturbance also another risk factor for post-op delirium and cognitive dysfunction. The other thing we have to be concerned with and apply is principles of enhanced recovery after surgery in orthopedic surgery. So those principles are roughly avoid prolonged fasting, early mobilization and commencement of nutrition, and minimizing drains and catheters unnecessarily. Not keeping these drains and catheters, and pain control integrated with physical therapy will improve the post-op recovery and shorten the morbidity and hospital stay. Regarding the specific considerations, first one is positioning. So we are considering positioning for patient safety one, because patients might fall during positioning and get trauma. They might be exposed for different electrical injury and so on. So the other is prevention of nerve injuries from compression and stretch, and we have to also maintain patent airway IV access and catheters. Proper monitoring is important during our position, and we have to also facilitate optimal surgical approach and create optimal surgical fit for the surgeon during our position. Certain positions are commonly used in orthopedics, even though there are multiple positions that can be used. So supine, bone, lateral, big chair, and fracture table can be used. So when we see the supine position, we mean by patient on back. So we have to consider of the pressure points like the occiput, the elbow, the scapula, the sacral area, the calcaneal area, and so on. So we have to pad these areas if it is a prolonged procedure, and arms should be on arm boards, and it can be abducted or it can be tucked by the side of the patient. So if it is abducted, we have to prevent more than 90 degrees of abduction to prevent stretch of the brachial plexus and injury. So hands should be supine, IV access should be patent, and elbow should be padded either ways. In arms tucked, finger should be visible and should be in neutral position. So in extreme stiff positions, like in Trendelenburg or reverse Trendelenburg, we have to avoid use of shoulder brace, not to cause compression to the brachial plexus and for nerve injury. Lateral positioning, neck should be in neutral position, and axilla should always be free by applying thoracic roll. Padding below the lateral malleolus of the dependent leg and the medial malleolus of the non-dependent leg is important, and also padding between the two knees is important. Arms should be parallel to each other, and padding between them should be applied. As you can see, this is the roll that's preventing the axilla from compression. Neck is neutral, and the arm is, this one is on a support. And we can apply a roll here also to keep the arm parallel. Prone positioning. Prone positioning, it can be head straight forward or head turned to the side, depending on the procedure. So we have to be concerned with our airway patency. So ETT placement and patency, we have to be concerned with pressure and damage to the eyes and ears. They should be free always, whether it's straightforward or to the side. Straightforward positioning sometimes associated with blindness if it is prolonged surgery, if there has been too much blood loss and so on. Ischemic optic neuropathy is a risk factor for blindness in this kind of position and so on. When the head is turned to the side, the other thing is you have to be careful of kinking of the vessel and occlusion. Dependent eyes and ears should be free of compression again. Arms can be tucked or abducted. Either ways, elbow should be padded and chest rolls should be applied. Iliac should be supported to make the abdomen free, not to increase abdominal pressure and chest pressure. Here, as you can see, special fixation with Mayfield is used here. Here, a horseshoe fixation is used on the bony prominences. Another is mirror shield can also be used so that we can monitor any pressure or anything, the fascial structures, and also we can monitor our patency of the airway. P-chair appearance, P-chair positioning, this is mostly used for shoulder procedures and also other procedures. So arms are supported by avoiding the ulnar nerve compression here. Brachial plexus should be prevented from stretching by applying this position. So one of the major concerns in this position is, one is venous return is decreased so that mean arterial pressure reaching to the brain is decreased, and cerebral perfusion pressure can be compromised. So we have to take that into consideration and manage our intravascular volume and mean arterial pressure accordingly to prevent ischemia to the brain. And also, sometimes patients might develop BGR reflex and they might go to cardiac arrest if you are not managing the intravascular volume adequately and prevention of decreased venous return. We can apply elastic stockings or active pressure leg compressions to increase the venous return disposition. Venous air embolism is also another concern during this position since it's a sitting position. Fracture chair. Fracture chair is mainly used on fractured extremity to allow close reduction and fixation. It also allows radiographic access to the fracture site in several planes. Genitalia should be protected when we are using the fracture chair. As you can see, there is a genital protection. Arm, ipsilateral arm can be supported with arm board or it can be slinged to the chest. Here's a C-arm can take imaging in any direction of the fractured extremity. Another major concern is bone cement implantation syndrome in orthopedic surgery, especially in arthroplasty. So this bone cement is also known as the methyl methacrylate, and it's commonly manifesting as hypoxia, hypotension, and change in mentation intraoperatively at the time of cementation, prosthetic insertion, and joint reduction. It can occasionally also occur during tourniquet deflation. This bone cement implantation syndrome can manifest also as fever, hypoxia, hypotension, tachycardia, dysrhythmia, and change in mentation. If we are using in-tidal carbon dioxide monitoring, there might be a decreased in-tidal carbon dioxide level, and we can see right ventricular failure, and at the end, if left untreated or if it is severe enough, cardiac arrest might be the end result. Our management approach is first prevention by increasing our FiO2 prior to cementing, and we have to also monitor and maintain hydration adequately. Once it happens, it will be a supportive management. So another management is create a ventilation hole in the distal femur, but this is associated with risk of fracture. High pressure lavage of the femoral shaft to remove the debris, and using a cementless prosthesis sometimes helps. The other embolization syndrome is fat embolism syndrome, and it's commonly associated with long bone fractures and pelvic fracture, particularly femoral bone fracture, and it's associated with mortality rate of 10 to 20%. So it manifests within 12 to 72 hours of long bone fracture and pelvic fractures. The common presenting thread are dyspnea, change in mentation, and petechial rash. So for diagnosis of fat embolism syndrome, we can use Bird's diagnosis of fat embolism syndrome criteria. So there are 3 major criteria and 5 minor criteria and other laboratory features. But for diagnosis, we need 1 major criteria, 4 minor criteria, and fat microglobulinemia, the laboratory feature, is important for diagnosis of fat embolism syndrome. So under general anesthesia, fat embolism syndrome can be detected by being vigilant to our monitoring. One is desaturation and also decrease in in-tidal carbon dioxide. If we are using monitoring for pulmonary arterial pressure, there will be rising pulmonary arterial pressure. And on the ECG, we might see ST segment changes that are consistent with myocardial ischemia, and also ECG changes consistent with right-sided heart strain. Our management strategy will be prophylaxis is by early stabilization of the fracture before fat embolization occurs. Once it occurs, there is no definitive treatment. It will be supportive care. So respiratory support with oxygen administration or mechanical ventilation if the patient requires. What do we need? Some of the patients, like 10% of the patients, might develop AR days. Out of those patients with AR days, 10% will require mechanical ventilation due to severe AR days. So invasive monitoring, we can use central venous pressure, invasive blood pressure monitoring, and pulmonary capillary wedge pressure can be also used for management of intravascular volume management, intravascular volume management, and our inotrope support. We have to treat pulmonary arterial hypertension with pulmonary arterial directors like milrinone or dobutamine, also support right-side heart failure. Corticosteroids are commonly used in fatty embolism syndrome, but their efficacy is debatable because researchers show different results. Another concern is tourniquet. The issue of pneumatic tourniquet, we use it to minimize blood loss and create a bloodless surgical field. So it can be sustained for 2 hours, but should not be used continuously for more than 2 hours. If we have to use continuous tourniquet, we have to give a 30 minutes break in between. We are going to have to use it for more than 2 hours. So if we use it sustained more than 2 hours, nerve injury, rhabdomyolysis, and transient muscle dysfunction are complications associated with tourniquet RDS. Disadvantages of inflation: pain, hypertension, tachycardia, and diaphoresis, mainly associated with increased sympathetic outcome, and arterial thromboembolism, pulmonary embolism, and also bruise or pressure necrosis of the skin can be complication. Also, deflation is associated with complication or disadvantage. So tourniquet deflation causes increased level of arterial carbon dioxide, lactate, and potassium, which are released from the ischemic extremity and tissues. Increased minute ventilation of spontaneous breathing will be there as a compensation for the transient metabolic acidosis, and core temperature might also decrease. We can prevent these complications by applying tourniquet in selective patients and by using wide, low-pressure cuffs and limit inflation time to 2 hours. And our maximum pressure, we can use 50 to 75 millimeters of mercury above the systolic blood pressure of the patient for the arm, and 75 to 100 millimeters of mercury above the systolic blood pressure for leg tourniquets. Doppler-guided inflation can also be used as an option, and adequate underneath padding will prevent bruising of the skin and necrosis of underlying tissue. Another major issue in orthopedic surgery is deep venous thrombosis and pulmonary embolism. These are major cause of morbidity and mortality after major orthopedic surgeries such as total hip arthroplasty, total knee arthroplasty, pelvic and hip fractures. The incidence of DVT in patients without prophylaxis can reach up to 40 to 60%. And the incidence of pulmonary embolism in these patients can be 10 to 20%, with fatality of 1 to 3% if left untreated. There are certain identified risk factors for this DVT and PE. One is obesity, older age, which is more than 60 years, previous incidence of DVT and PE, cancer, mainly pelvic cancers, and procedure that lasts more than 30 minutes, lower extremity fractures, use of a tourniquet, immobilization for more than 4 days, and thrombophilia. It can be hereditary thrombophilia. Prevention, we can use pharmacological or non-pharmacological prevention of these venous thromboembolism events. So intermittent pneumatic compression is among the non-pharmacological ones. We can use also elastic stockings, and we can use inferior vena cava filters. IVC filters can be used for those patients at high risk for PE, but with contraindication for anticoagulants. Pharmacological prophylaxis, we can use unfractionated heparin, low molecular weight heparin, and other direct oral anticoagulants can be used. Treatment, mainly is anticoagulants for the DVT, and if there is a severe fatal PE, thrombolytics can be administered, and also supportive cares. The other major issue is the use of regional anesthesia in patients on anticoagulation in orthopedic surgery. So we have to plan ahead for postoperative anesthesia as we are planning for the anesthesia for patients on anticoagulation. So this is mainly associated with central neuraxial blocks and deep peripheral blocks or plexus blocks. For other superficial peripheral blocks, we have to weigh the risk-benefit, vascular proximity, and whether compression and arrest of bleeding is possible or not is our concern regarding superficial peripheral nerve blocks. So when we consider these issues, we have to follow certain guidelines. Here I have put the American Society of Regional Anesthesia guideline regarding antiplatelet agents. Here is just for the common antiplatelet types like aspirin and clopidogrel. So for aspirin, if it is used alone and if there is no other concomitant use of anticoagulation, there is no additional precautions needed to administer neuraxial block while the patient is on aspirin or to continue therapy while the patient is on neuraxial catheter in situ or to resume treatment after the catheter is removed. The same for non-steroidal anti-inflammatory drugs. But for clopidogrel, we need 5 to 7 days of cessation of administration of these drugs before we administer a central neuraxial block or deep plexus blocks. For maintaining catheter, we can use it 1 to 2 days while the patient is on clopidogrel. We can maintain our neuraxial catheters. After removing the catheter, we can restart the clopidogrel immediately. But if we are administering a loading dose, we should wait 6 hours at least. This is for the maintenance dose or low dose 75 milligrams. Regarding the issue of heparin and fractionated heparin, our consideration will depend on whether it's administered through subcutaneous route or intravenous route. The other is if it is received for more than 4 days, we have to perform platelet count because the risk of heparin-induced thrombocytopenia is high in these patients. The other is we have to also determine coagulation profile before we administer central neuraxial block. The other issue is we have to consider whether it's low dose prophylaxis or high dose prophylaxis, or if it is therapeutic dose matters, whether to give central neuraxial block or how many hours do we have to discontinue this therapy before we give central neuraxial block, whether we have to keep indwelling block catheters or when can we remove the block catheters after the last dose of anticoagulants, when can we reinitiate anticoagulant therapy after removal of our central neuraxial or peripheral neuraxial catheters. So regarding low molecular weight heparin, same consideration whether if it is prophylactic dose or treatment dose matters. For prophylactic dose, we have to wait for 12 hours. And same if it has been received for more than 4 days, we have to perform platelet count. And if it was treatment dose, we have to wait 24 hours before administering central neuraxial block. And in high-risk patients, we can consider determining anti-factor 10A level before we administer central neuraxial block. So for prophylactic doses, we can maintain our catheter in place while the patient is receiving prophylactic dose, but we have to restart prophylactic dose 24 hours after catheter placement. And catheter can be removed only 12 hours after the last dose. Treatment dose, keeping a catheter while the patient is receiving treatment dose of low molecular weight heparin is not recommended. The other is regarding the direct oral anticoagulants. So there are, here we can see the POSE and the ASRA guidelines. POSE is perioperative anticoagulation use for surgery evaluation. It's based on randomized controlled trials, while the ASRA guideline follows expert consensus. So for this direct oral anticoagulants like rivaroxaban, apixaban, edoxaban, dabigatran, the POSE strategy recommends discontinuation for 48 hours preoperatively, and the ASRA guideline recommends discontinuation for 72 hours preoperatively. For postoperative, the POSE guideline recommends discontinuation for 48 to 72 hours, while the ASRA guideline recommends discontinuation for 24 to 72 hours, depending on patient risk. Regarding dabigatran, if the creatinine clearance is less than 50 ml per minute, we have to discontinue for 5 days or under 20 hours preoperatively or before administering central neural block or for administering a deep plexus block, because dabigatran is heavily dependent on renal resuscitation. Other issue is most of the orthopedic patients, especially presenting for joint replacement surgeries or the elderly, are exposed for rheumatic arthritis or osteoarthritis. So if there is rheumatoid arthritis, our consideration will be the airway. So there will be limited temporomandibular joint movement, and there will be narrow glottic opening due to cricoarytenoid joint arthritis. And also the cervical spine, we have sometimes atlantoaxial instability. This poses great risk for cervical spinal cord trauma while we are managing the airway. So fiber optic bronchoscope or video laryngoscope should be used for this kind of patients' airway management. And also we might be ordering a preoperative cervical CT scan or cervical X-ray in lateral. Regarding the cardiac, patients are, some of them will have pericarditis, cardiac tamponade. They might have diffuse interstitial fibrosis. So we have to make a thorough preoperative evaluation, and we have to plan our anesthetic management accordingly. For osteoarthritis patients, the same airway management difficulty risk is there. And also patients will have difficult neural block mostly. Positioning might be difficult due to stiff joint, and also they are at risk for trauma during positioning. Ankylosing spondylitis, this is part of the spondyloarthropathy, and the anesthesia considerations, the same difficult airway management will be there. Neuraxial block might be sometimes difficult or impossible with some techniques, and positioning might be difficult, and patients are at risk again for trauma during our positioning, because their vertebrae are rigid due to ossification of the ligaments starting from the lumbosacral area, progressing towards the cranial area through the cervical spine. These patients might have associated cardiac defects like aortic insufficiency, conduction defect, or pleural effusion. Another major surgery in orthopedics is spinal surgery. So spinal surgery can be performed for many reasons. As an example, can be for spinal cord compression, can be for intervertebral disc herniation, spinal deformity, post-traumatic stabilization, and so on. And we have to give due emphasis for preoperative evaluation, like our airway assessment, cardiovascular, respiratory, and neurological evaluation in these patients. Spinal surgery can be cervical, thoracic, or lumbosacral spine surgery. And positioning also matters. It can be prone position in some of the surgeries. So we have seen the concerns associated with prone positioning. So patients are at risk for loss of their airway patency, vascular access, thinking of the major vessels, peripheral nerve damage, abdominal compression, chest compression, and so on. Ears, eyes, nose, breast, and genitalia should be protected from excess pressure in this position. And patients are also at risk for blindness if it is prolonged, if it involves major blood loss, and so on. Another concern is monitoring. Apart from the ASA standard monitoring, we can use invasive monitors like central venous pressure, invasive blood pressure, and other monitors also can be applied. And neuromonitoring specifically can be used for somatosensory evoked potential, motor evoked potential, and electromyograph can be used. Our concern here is inhalational anesthetics should be used in the minimal concentration. They should not be used more than 0.5 mean alveolar concentration. That is because they affect the amplitude of this neuromonitoring. And also specifically for motor evoked potential, the use of neuromuscular blockers should be limited. Nitrous oxide is, as much as possible, it should be avoided in this kind of neuromonitoring procedures. Formerly, this monitoring used to be executed by awakening the patient in the middle of the surgery, but it's associated with some risks like due to agitation and movement, instrumentation can be dislodged, patients might have severe pain and so on. So now neuromonitoring is a good standard for these procedures.
I'm sorry for the interruption, Dr. Dagmawi. Thank you so much for the insightful presentation, but we want to be respectful of everyone's time, and unfortunately, we only have 5 minutes for this presentation. So please feel free to start concluding at your convenience. Thank you.
Thank you. I just need 2 minutes. Thank you. So regarding pediatric orthopedic surgery, patients mostly cerebral palsy, patients with cerebral palsy will present for deformity correction surgeries. So these patients usually have bronchopulmonary dysplasia, tracheomalacia, and so on. And due to contractures and impaired neck rotation of movement, they often have a difficult airway. So video laryngoscope or fiber optic bronchoscope use is warranted in this kind of patients. And gastroesophageal reflex also sometimes will be there due to loose lower esophageal sphincter tone, and it increases the risk of pulmonary aspiration. So rapid sequence induction should be used in this kind of patients, and adequate postoperative nausea and vomiting prophylaxis should be administered. They might have seizure disorder, so regarding their medication, avoidance of hypoxia, hypercarbia, hypotension, and anything that triggers seizure, any medication should be avoided, and they have to continue their anticonvulsants if the anticonvulsants are in accordance with our anesthetic management. They are also at risk for intraoperative hypothermia. These patients pose difficulty for positioning, and they have a risk for nerve injury due to extensive contracture and spasticity. So we have to take these issues into consideration for these patients. The other is juvenile rheumatoid arthritis. This patient is most often have the cervical spine fusion and hypoplastic mandible, which poses a difficult airway. And also they might have lumbar hyperlordosis, which complicates our neuraxial anesthesia and analgesia management. So the key take-home message from my discussion will be anesthesia choice affects pain, mobility, and safety. Regional analgesia with multimodal analgesia is standard, and ERAS improves outcome when implemented. Vigilance for bone cement implantation syndrome, embolic events, delirium, and venous thromboembolism should be given, and multidisciplinary approach derives the best results. These are my references, and thank you for attentively listening to me, and sorry for taking much more time than I was allocated. And if you have any questions or comments, you're welcome. Thank you very much.
Thank you, Dr. Dagmawi. We will take the questions at the end of our second presentation. It is a great pleasure to introduce Ms. Zinat Atif, a public health specialist and mental wellness ambassador at the Asian University for Women in Bangladesh. Ms. Atif is deeply passionate about advancing mental health awareness and emotional well-being, especially within academic and healthcare settings. Her work focuses on strengthening psychological resilience, promoting emotional support systems, and preparing young professionals and students to better navigate stress in challenging environments. In addition to her public health work, she is a leadership trainee with the Aspire Institute, a global leadership initiative founded in partnership with Harvard University, where she continues to expand her impact in community engagement and global health leadership. Through her advocacy and leadership, Ms. Atif brings an important perspective to healthcare by highlighting the critical connection between psychological well-being and patient outcomes. Her insights remind us that successful surgical care extends beyond clinical procedures and includes emotional and mental preparedness. Today, she will be speaking on psychological preparedness before surgery, reducing anxiety and improving surgical outcomes. Please join me in warmly welcoming Ms. Zinat Atif.
Thank you, Ms. Sikria, for the kind introduction. I hope I'm audible. Yeah? Hello?
Yes, Ms. Atif, we can hear you perfectly fine.
Okay. Thanks, Ms. Zikria, for the kind introduction, and thanks to Professor Adibusala for giving me this opportunity to attend as a guest speaker here in Torque today. Um, good morning, good evening, and good afternoon, everybody. I'd like to share my slides now. The presentation is visible, I hope.
Perfectly visible.
Okay. Today, I will discuss the role of psychological preparedness before surgery and how reducing anxiety can improve both patient experience and surgical outcomes. So when we think about surgery, we often focus on the technical or physical aspects. However, emotional and psychological readiness also plays a very critical role in recovery and overall patient well-being. So here is a brief slide of what I'll be covering. I'll be covering the importance of psychological preparedness before surgery, discussing how preoperative anxiety affects patients mentally and physically, the role of healthcare professionals in reducing stress, and how proper mental preparation can improve overall surgical outcomes in recovery. So, before discussing psychological preparedness, it's important to understand the surgery is not only a physical experience for patients. It's also an emotional and psychological experience. And for healthcare professionals, surgery may be a routine medical procedure. But for patient, it can feel life-changing and frightening. Many patients worry about actually the pain, anesthesia, complications, disability, and even death sometimes. But even when the surgery is considered minor, patients may still experience severe emotional stress. This anxiety can begin days or even weeks before the operation. Psychological stress, even before surgery, is important because the mind and body are deeply connected. When a patient is stressed, the body activates stress and hormones such as cortisol and adrenaline and etc. This can increase heart rate, BP, blood pressure, muscle tension, and sometimes fear responses. Additionally, modern healthcare is increasingly focusing on holistic care. So you may be thinking about what is holistic care. Holistic care means treating the patient as a whole person, physically, emotionally, socially, and psychologically. This is where psychological preparedness become extremely important. When patients feel emotionally supported and mentally prepared, they're more likely to cooperate with healthcare professionals, manage pain better, and they recover more positively. This is why psychological preparation should not be viewed as an optional extra service. It should be considered as a part of quality surgical care. Now, I will I will go deeper on what is psychological preparedness. Psychological preparedness refers to helping patients become mentally and emotionally ready before surgery. So, this can include reducing fear, improving understanding, increasing emotional stability, and helping patients feel supported throughout the surgical journey. And a psychologically prepared patient understands what will happen before surgery and during the operation and during the recovery. So this understanding can reduce uncertainty, and reducing the uncertainty often reduces the fear, which is really important. Psychological preparedness also helps patients feel more in control. One major cause of anxiety is the feeling of losing control over one's body and situation. But when healthcare professionals communicate properly and prepare patients emotionally, patients usually develop greater confidence in the medical team. So some of the preparedness can include like explaining the surgical procedure clearly, discussing the possible risks honestly, or kind of allowing patients to ask questions freely. So in public health and healthcare systems, psychological preparedness is part of patient-centered care. That's why it respects the emotional well-being of patients instead of focusing only the technical procedure. Uh, another another main point is the understanding preoperative anxiety. What is preoperative anxiety? Preoperative anxiety refers to emotional stress, nervousness, fear, or worry experienced before surgery. And researches suggest that a large percentage of surgical patients experience anxiety before their operation. In many cases, patients may appear calm extremely while internally experiencing significant emotional distress. And the intensity of anxiety differs from person to person, obviously. Some patients may only feel mild nervousness, but some others experience panic attacks, insomnia, or crying, or severe emotional distress. Additionally, anxiety before surgery is important because it affects both the mind and the body. Psychologically, anxious patients may feel hopeless, fearful, emotionally unstable, or overwhelmed sometimes. And anxiety activates, as we all know, that as the anxiety activates the body's stress response system. This can also increase the blood pressure, heart rate, muscle tension, and stress hormone levels. So some of the common like patients with severe anxiety may also include uh, difficulty in sleeping, experiencing more post-operative pain, and sometimes they show difficulty cooperating with healthcare stuffs. In some of the cases, anxiety may even lead patients to delay or avoid necessary surgery. This demonstrates why mental preparation before surgery is not only beneficial or emotional well-being, but also clinically important, right? So there are some common causes of surgical anxiety I've mentioned here. Patients may experience anxiety for many different reasons before surgery. Uh, One of the main common fears is pain. We all may have experienced that. Patients often worry about the how painful the surgery or recovery process may be. Or another major concern is anesthesia. Some patients fear not waking up after anesthesia, while others fear waking up during surgery. Patients may also fear complications, long recovery periods, or infections, or sometimes permanent disability. In many cultures and communities, surgery itself is viewed as something dangerous, which can increase emotional fear. Lack of information is another major factor. When patients do not fully understand what will happen, uncertainty increases the anxiety even more. Financial concerns can also create stress, especially in settings where healthcare costs places pressure on families, right? Patients who previously had traumatic medical experiences may experience stronger emotional reactions before another surgery. Some elderly patients fear becoming dependent on family members after surgery, while younger patients may worry about returning to work or normal activities. Understanding these causes is extremely important because it helps healthcare professionals provide more individualized emotional support. For the next slide, I'll be focusing on why psychological preparation matters. Psychological preparation matters because emotional well-being directly affects physical health outcomes. When patients are mentally prepared, they feel more confident and less fearful about surgery. Some of the prepared patients are usually more cooperative during pre-operative and post-operative care. They're more likely to follow some of the instructions related to medication, fasting, mobility, breathing exercises, these kind of things. Mental preparedness also enhances the communication between patients and healthcare professionals. So patients feel more comfortable asking questions and expressing their concerns. And studies also suggest that psychologically, prepared patients often report lower pain intensity after surgery. So this happens partly because anxiety increases sensitivity to pain. When anxiety decreases, patients may perceive pain differently and cope with the discomfort more effectively. Psychological preparedness also can improve recovery experiences by reducing emotional distress or panic and confusion after the surgery. And some of the patients who feel emotionally supported usually report greater trust in health systems and higher satisfaction with their care. From a public health perspective, improving the patient experience and recovery can also reduce healthcare burden by improving efficiency and reducing some of the complications. For the next slide, I'll be talking about effects of anxiety on surgical outcomes. Anxiety does not only affect patients emotionally, it also creates a significant psychological effects that can directly influence surgical outcomes and recovery. When a patient becomes anxious, the body releases stress hormones such as cortisol and adrenaline that I've mentioned it before. And this can increase heart rate, the BP, and muscle tension. These psychological changes can make anesthesia management more difficult, even more difficult during surgery, and may also increase the risk of complications. Additionally, anxiety can heighten pain perception after the surgery, meaning that anxious patients often report feeling more severe pain compared to calmer patients undergoing the same procedure. High stress levels also can weaken the immune system responses, uh, or maybe the delay wound healing and prolonging the recovery time, the period of time. Additionally, anxiety or anxious patients may experience sleep disturbance, fatigue, and it affects their recovery also. Severe anxiety can even increase the duration of hospital stay and reduce and reduces overall patient satisfaction with healthcare services. For example, if two patients undergo the same surgical procedure, the patient with lower anxiety may recover faster and cooperate more effectively with treatment, while the highly anxious patient may experience greater pain, emotional distress, and slower healing. So this clearly demonstrates that psychological well-being and physical recovery are closely connected in surgical healthcare. For the next slide, I'll be talking about vulnerable patient groups. So by this, I mean who are at the high risk of this the situation. Not all patients experience surgical anxiety in the same way, because certain groups are more psychologically vulnerable than others. Like children, for example, often becomes anxious because they fear separation from their parents, and injections, pain, and unfamiliar hospital environments. Elderly patients may worry more about surgical complications, slow recovery, or losing independence after the operation. Patients who previously had traumatic medical experiences may also develop stronger anxiety because past negative memories influences their expectations about future procedures. Individuals who already suffer from mental health conditions, such as we can mention about generalized anxiety disorder or depression, or usually more emotionally sensitive before surgery. Similarly, patients undergoing major surgeries like cancer surgery or heart surgery often experience intense fear because they associate the procedure with life-threatening conditions. Another important factor is low health literacy. Because patients who do not fully understand medical information often become more fearful and confused about the treatment process. For example, a child may panic simply because they do not understand why they're being taken into the operating room, right? While an elderly patient may fear not waking up after anesthesia. So this is why healthcare professionals should provide individualized emotional support according to the specific psychological needs of each individual patient group instead of using the same approach for everybody. For the next slide, there is a chart of psychological interventions and their benefits. Psychological interventions are techniques which are there to use to reduce emotional distress, fear, and anxiety before surgery. And they are extremely important because anxiety can negatively affect both surgical outcomes and recovery. These interventions help patients feel mentally prepared and emotionally stable before entering the operating environment or room. Counseling also allows patients to openly discuss their fears and receive reassurance from the healthcare professionals, which often reduces uncertainty and panic. The relaxation techniques such as deep breathing exercises help slow the heart rate and calm the nervous system by reducing psychological distress uh, responses. And also meditation and mindfulness techniques encourage patients to focus on the present moment rather than the imagining worst case scenarios related to the surgery. My favorite one is the music therapy is another useful intervention because uh, calming music creates a relaxing environment and distracts patients from fear and tension. Cognitive behavioral therapy is another one as known as the CBT, helps patients identify negative thoughts and replace them with more realistic and positive thinking patterns. Preoperative education is also highly effective because patients tend to feel less afraid when they clearly understand what will happen before, during, and after the surgery. For example, a patient who practices breathing exercises and listens to calming music before surgery may experience lower stress levels and greater emotional control compared to a patient who receives no psychological support. So, one important point is that these interventions are usually low cost, non invasive, and highly effective in improving patients' well being, overall well being. For the next slide, I'll go deeper about what is the role of the communication and healthcare teams here. Communication plays an extremely important role in reducing surgical anxiety because many patients become more fearful when they do not fully understand the surgical process. When healthcare professionals explain procedures clearly using simple language, patients feel more informed or more involved and emotionally secure. So, good communication allows patients to openly express their fears and concerns instead of suppressing them. And even small things such as maintaining eye contact, speaking calmly, or listening attentively, and reassuring the patient can create a strong sense of trust and comfort. So, different members of the healthcare team contribute in different ways to reducing anxiety. Doctors usually explain the diagnosis, treatment plans, or the risks and some expected outcomes of the surgery. Nurses often spend more time with the patients, so they provide emotional reassurance, monitor psychological responses, and patients remain calm before the procedure. Psychologists, or we can say counselors, may help patients manage severe stress through coping strategies and relaxation techniques. Family member also play a very significant emotional role because their support often makes patients feel safer and less isolated. For example, if a nurse calmly explains that the patient will be continuously monitored during a surgery and effective pain management will be provided afterward, the patient often becomes noticeably less anxious. This shows that the communication itself can act as a therapeutic tool in healthcare settings. So here, for better understanding, I come up with a case study. There is a scenario. A 45-year-old woman scheduled for orthopedic surgery experienced severe anxiety, insomnia, and fear of anesthesia. So, in this case study, we can see how anxiety develops in patients even before the surgery actually begins. The patient was experiencing emotional stress because surgery is commonly associated with fear or pain, and especially uncertainty and possible complications. Before the operation, the patient showed signs of anxiety such as difficulty sleeping, rapid heartbeat, or sweating, restlessness, or uh, sometimes the patients repeatedly ask the same questions about the surgery outcomes. This emotional distress also affects the patient's confidence in the healthcare process and made them less cooperative during preparation. But on the other hand, after receiving proper counseling, reassurance, and emotional support from healthcare professionals, the patient gradually became calmer and mentally more prepared for the surgery. This case study clearly demonstrates how proper communication and emotional support can improve patient cooperation or in the case of reducing stress levels and positively influence recovery outcomes. For instance, a patient preparing for heart surgery uh, may fear death or severe complications despite the surgery having a high success rate. And this fear alone can increase blood pressure and make the surgical preparation more difficult. And this is all. Thank you for your attention.
Thank you, Ms. Atif, for your presentation on psychological preparedness before surgery. I believe this is a very important topic that is not always discussed enough in healthcare. I would also like to thank Dr. Dagmawi for his presentation. It highlighted the importance of safe planning and safe practice throughout the surgical process. Thank you again for sharing your knowledge and experience with us today. We will now begin our 10 minutes Q&A session. I will try to take as many questions as possible, so please feel free to post your questions in the chat box and kindly mention the name of the speaker your question is directed to, as we have two speakers with us today. We will now begin with our first question, which is for Ms. Atif. It asks, how can anxiety before surgery affect a patient's recovery after the operation?
Can you please repeat the question again?
Of course, it says, how can anxiety before surgery affect a patient's recovery after the operation?
Yeah. Thank you for the question. So, anxiety before surgery can affect recovery in several physical and emotional ways that I've also mentioned in my slides before. When a patient becomes highly stressed, the body releases stress hormones such as cortisol and adrenaline. These hormones increase the heart rate, the blood pressure, and the muscle tension, which can also make the body feel more exhausted and uncomfortable. Uh, Even patients with high anxiety levels may also experience stronger pain after surgery because stress increases pain sensitivity. As we know that anxiety can disturb our sleep, I also mentioned it in my slides, reduce the appetite or weaken the emotional stability. Some anxious patients may also struggle to follow medical instructions correctly because they remain emotionally overwhelmed, and recovery may become slower and hospital stays may become longer. This is why managing anxiety before surgery is important, not only for the emotional comfort, but also for the improving or enhancing the physical recovery.
Absolutely, thank you. The next question is from Qudsiya Karimi. It says, my question is for Ms. Zinat Atif. How can healthcare teams identify whether a patient is experiencing severe surgical anxiety?
Okay. I think this is a really great point to mention. Healthcare teams can identify the severe surgical anxiety by observing both emotional and physical signs. That's already shown by the patient before surgery. Emotionally, patients may appear extremely nervous, fearful, or restless, or may repeatedly ask the same questions about the surgery outcomes. Some patients may also cry or panic or struggle to concentrate during the conversations. But physically, anxiety can cause symptoms such as the rapid heartbeat and sweating, shaking, and high BP, as I also mentioned it before. Also, healthcare professionals assess the patient's behavior, the way they communicate, and their medical history to understand the severity of anxiety. But most importantly, early identification is important because it allows doctors and nurses to provide emotional reassurance or surgical interventions before the surgery. So, yeah.
Thank you. The next question is also for Ms. Atif. It says, why should psychological support be considered an important part of preoperative care?
Oh, we know that surgery affects patients mentally, also physically. And psychological support should be considered an important part of preoperative care because many patients experience fear, stress, uncertainty before surgery, and these emotions can negatively influence recovery and cooperation with the treatment. So psychological support helps patients feel calmer, emotionally stable, and more prepared for the surgical process. So there are some techniques such as counseling, breathing exercises. I also made a chart for that in my slides, and relaxation therapy and patients' educations. For example, I want to bring an example here for better understanding. A patient preparing for major heart surgery may become extremely anxious after thinking about possible complications or sometimes even death. If healthcare professionals provide emotional reassurance or maybe explain the procedure clearly and teach relaxation techniques, and the patient may feel more confident and mentally prepared. That's why the patient is likely to cooperate with better with treatment and experience a smoother recovery process after the surgery.
Thank you. The next question says, what are the complications for heavy smokers, specifically marijuana, on the day of surgery for anesthetic? And this one is for Dr. Dagmawi.
Okay, thank you. Specifically for marijuana smokers, heavy smokers on the day of surgery, as we all know, marijuana contains two chemicals mainly that are the most physiologically effective chemicals, the THC and CBD. It's associated with an increased requirement for anesthetic drugs, particularly propofol. So propofol, if we are using propofol for induction of anesthesia or maintenance of anesthesia, the patients will have an increased requirement. And the other issue with heavy smokers of marijuana will be one is their ventilatory effort will be changed. Their cardiovascular response to anesthesia will also be changed. Like they will have unpredictable blood pressure, for example. Some may manifest hypotension, some may manifest hypertension, and we have to tailor our anesthesia drugs accordingly. And they might require post-operative ventilation if they are a heavy smoker and if they are smoking on the day of surgery and anesthesia. Because secretions will be increased, airway will be reactive, just like heavy cigarette smokers, and also patients will be at risk for post-operative pneumonia, and also their post-operative pain management will be affected. They will have increased requirement for post-operative analgesics. So these are the main concerns, but this topic is under research currently.
Thank you, Dr. Dagmawi. As I mentioned before, we want to be respectful of everyone's time. So this should conclude our Q&A session. Thank you so much for everyone for participation and asking questions. And we will now move to our closing remarks.
Thank you so much, Farhat. Thank you so much to Ms. Zinat and Dr. Dagmawi for the session. My name is Dr. Ian Sote, a medical doctor from Nairobi, Kenya. And on behalf of the Operating Room Global, I would like to sincerely thank our speakers for their valuable insights and our participants for joining us from across different countries, time zones, and professional backgrounds. We recognize that many of you are participating despite busy clinical schedules, varying internet access, and language differences. We truly appreciate your commitment to learning and to improving surgical and perioperative care in your local settings. Please feel free to share key lessons from today's sessions within your teams, institutions, and professional networks as part of strengthening safe and effective practice globally. We encourage you to stay connected with TORG through our upcoming webinars, training programs, and research activities, which are published on our website across our official platforms. Also, to receive your TORG accredited training certificate, please do note the following. Immediately after this session, the evaluation and certification form will open automatically in the browser on your device and remain active for 24 hours only. Number 2 is the certificates are issued within 5 to 7 working days after successful submission. Evaluation is mandatory for accreditation, and certificates are linked to your TORG membership ID. Once again, thank you for being part of the TORG global community. We wish you a safe, productive day or evening ahead, wherever you're joining from. Thank you once again for joining us, and we look forward to supporting your continued professional development with the Operating Room Global. Thank you, everyone.